Excellent, thanks. I'm Brenna. I'm the director of the Nourished Research Foundation in Boulder, Colorado. I'm also an associate professor at the National University of Natural Medicine in their clinical research department. I'm a faculty on the Bridge program, which is a federally funded research program that provides postdoctoral training. I'm also an adjunct associate professor at Naropa University, which is a Buddhist-oriented university here in Boulder, Colorado. I teach in the graduate program, in their clinical mental health counseling master's program, and in the undergraduate department. And because I've got my screen on a monitor, I'm just going to turn my video off so that you're not looking at my neck if I can here. Okay. So I want to give a disclaimer before I start that this presentation might contain content related to oppression, invalidation, marginalization, discrimination, bullying, abuse, and trauma, both generally and specific to populations of racial, ethnic, sex, gender, and socioeconomic status minorities, because binge eating disorder contains oppression, invalidation, marginalization, and all of those factors. If at any time you feel activated by any of this content, I encourage you to please feel free to take care of yourself, move through your space, leave, return, whatever you need. So I'd like to start, if you'll indulge me, with a little contemplation exercise. So I'm going to ask everyone to close their eyes for a moment and imagine that you have a patient or a family member or a friend who comes to you and expresses negative emotions around eating. Maybe they describe having feelings of guilt, shame, loss of control when they eat. I want you to think about how you might respond. Are there any follow-up questions you might ask them? And I want you to just notice if there's any imagery that comes up for you about that patient, friend, or family member that you're imagining. Specifically, is there any particular body shape or size, any particular sex or gender identity, any particular race or ethnicity, socioeconomic status, or age? And when you're ready, you can open your eyes. We're just going to set that aside for a moment, and we'll return to that a little bit later. Thanks for indulging me. So, I have a PhD in biomedical science and neuroscience that was funded by my advisor's grant from NIDA, the National Institute on Drug Abuse, by the NIH. My postdoctorate training focused on complementary and integrative health, and that was directly funded by the NCCIH, the National Centers for Complementary and Integrative Health, which is an umbrella center of the National Institute of Health here in the US. The research that I'm going to be presenting is from a cross-sectional mixed method study that I conducted during my postdoc that focuses on experts' opinions about binge eating disorder. This is the first publication from that work. It's titled Binge Eating Disorders, a Social Justice Issue. Focuses largely on environmental factors that experts most commonly and most robustly endorse as being associated with binge eating disorder. If you want to scan the little QR code, that should take you to the publication if you'd like to follow along. We also have several other publications already from this project. So on the left is the publication I just showed. That was published in 2022. We also published in 2022 a publication on mental health aspects of binge eating disorder and then clinical aspects of binge eating disorder. And last year, 2024, we published a very large publication on complementary and integrative health use in binge eating disorder from this same study. We're working on a follow-up narrative review. And we're getting ready to submit a publication on treatment access barriers, which will be accompanied by a narrative review and a call for action kind of public policy piece. We also have several other publications kind of on the run. So binge eating disorder is a DSM-5 diagnosis. It's characterized by 2-hour binge eating episodes that occur at least weekly for at least 3 months, in which an individual rapidly consumes large amounts of food. That's a pretty subjective statement. Larger than others would in the same context, associated with loss of control and distress. Those are core diagnostic features in the APA. feelings of disgust, guilt, or shame without compensation or purging. This criteria of larger than others would under similar contexts can make diagnoses quite challenging in adolescent populations or in athletes, pregnant women, things like this. This is a fairly new diagnosis again, so it just became recognized as an autonomous diagnosis in the DSM-5. It has very high rates of comorbidity, so 89% mental health comorbidities, 63% comorbidity with substance-related and addictive disorders, 61 to 55% comorbidity with depression and anxiety, 31% comorbidity with PTSD or other trauma and stress-related disorders, 8% with neurodivergence, as we know of, though that doesn't tend to be queried as much in research historically. And it often, these comorbidities, it often goes undiagnosed. So we often see binge eating disorder used to cope or mask for untreated symptoms. So an individual may have PTSD, may have neurodivergence, and use binge eating to cope for it when that issue is not being addressed. It also has 80 to 90% comorbidity with physical health outcomes. So 40 to 70% comorbidity with lifetime obesity, diabetes, metabolic syndrome, cardiometabolic disorder. Though we do have some emerging data showing that overweight and obesity may not necessarily increase risk for health outcomes, negative health outcomes, so cardiometabolic disorder in individuals with binge eating disorder. And I'll circle back to that in a little bit. It significantly impairs daily life, so it accounts for 0.98 disability adjusted life years per person. That's 9.8 disability adjusted life years per every 100 individuals. 0.8 million disability adjusted life years in total. That's from the 2019 Global Disease Burden Database, so fairly recent data. It has high lifetime prevalence rates that are estimated at 23 to 31%, both globally and nationally in the US. 23 to 31%. The 2019 Global Disease Burden Database found estimated a lifetime prevalence rate of 23.4%. So 23.4% of adults in their lifetime globally will experience binge eating disorder. Those rates are actually the same as substance-related and addictive disorders, anxiety, and depression. Yet, we usually don't think of binge eating disorder as a major public health crisis. I would argue that it most certainly is. The 2024 Growth Analysis Report reported that the binge eating disorder market is valued at 0.81 billion US dollars in 2024. They state that this is driven by increasing awareness, advancements in treatment options, and the rising prevalence of the disorder across 8 major markets. And it has a 6% compound annual growth rate estimated between 2025 and 2034. So it is only estimated to grow by quite a bit. The 2034 estimated market value is 1.45 billion US dollars. Standard of care interventions for binge eating disorder include eating disorder focused cognitive behavioral therapy. So this would be Chris Fairbairn's cognitive behavioral therapy, behavioral weight loss, interpersonal therapy, and pharmacotherapies. Pharmacotherapies tend to center around selective serotonin reuptake inhibitors, SSRI, antidepressants like escitalopram, sertraline, anticonvulsants like topiramate, anti-obesity medications like orlistat, though at least in the US, the FDA has pulled that approval, so it's no longer FDA approved because of safety risks. Vyvanse or lisdexamfetamine, which is a stimulant, an amphetamine stimulant developed for ADHD and is actually approved in the US for treating binge eating disorder, though it's not recognized as a guideline or standard care. And then, of course, it is recognized as a guideline, GLP-1 inhibitors, which have increasing use. These would be things like Ozempic, Wegovy. They do have some good empirical support, though they are not recognized yet as guideline or standard of care. Other evidence-based treatments or practices that have increasing use would include family-based therapy, other psychodynamic therapies, humanistic therapy, dialectic behavioral therapy, guided self-help versions of cognitive behavioral therapy, DBT, and then mindfulness-based stress reduction or mindfulness-based interventions. All of these standards of care have very low treatment success rates that cap at about 45% at best, even when combined. They have high recurrence rates. So of those who do have success, 50 to 65% of them relapse. They have high rates of treatment dissatisfaction and high rates of early discontinuation of care. This is very similar to treatment-resistant depression, which has a very large amount of funding, is something most folks are aware of. I'm guessing that most folks on this meeting were not aware of that in the case of binge eating disorder. Moreover, studies show us that most individuals who have binge eating disorder don't know that they have an eating disorder. So national and global survey data both show that about 95% of folks who meet diagnostic criteria for binge eating disorder never receive a formal diagnosis. 95% don't know themselves that they have an eating disorder. 95% don't recognize the need for treatment. 56 to 87% never receive standard treatment, and 85% lack access to health care. Given the current administration changes in the US, I suspect that percentage rate is only going to increase in the next couple of years. An issue in the field that we're gaining awareness around in research, but that really hinders binge eating disorder detection, screening, diagnosis, and treatment is what we call the SWAG stereotype. It's an outdated misconception that ascribes all eating disorders to skinny, white, affluent, young women or girls, SWAG, usually with restrictive type eating disorders. So I want you to think back to the visualization exercise that we did in the beginning here and just kind of notice, did the person who you were visualizing match any of those demographics? Now that demographic, thin, white, affluent young women, tend to saturate treatment-seeking populations for eating disorders. They also tend to saturate allopathic healthcare in general, at least here in the US. However, they are not an accurate representation of everyone who experiences binge eating disorder. As I said, 85% of folks with binge eating disorder lack access to healthcare, 95% never receive a formal diagnosis, and often themselves don't know that they have an eating disorder. Unfortunately, historically, researchers tend to pull from treatment centers and treatment-seeking populations. So that SWAG demographic not only saturates treatment-seeking populations, but it also tends to saturate research that informs what we think we know about binge eating disorder. And again, that demographic actually represents less than 5% of all individuals who experience binge eating disorder. I wrote eating disorders just because I couldn't fit binge eating disorder in one line on the slide. So we have an issue, and this is something that was reported to me in my research by experts. It's well documented also in the literature, but we have this situation where, what we think we know about eating disorders pulls from a sample that does not have good face validity for the population. So a quote from one of the experts in my study, and I'll talk a little bit more about the methods of my study in a little bit. So much of the eating disorder perspectives and history that we attend to are very female focused and come out of the female gender orientation. I think anorexia nervosa kind of set the stage for a current understanding of eating disorder pathology and treatment. And anorexia nervosa is so dominantly female in treatment-seeking populations. We know that unfortunately eating disorders have been hampered by these old stereotypes about who's affected, and that leaves millions of people undetected with an eating disorder. So the SWAG stereotype, it needs dismantling and it needs awareness. One of actually the benefits to come out of the COVID-19 pandemic was that it put a firewall between research and treatment-seeking populations. So as researchers, we had to get a little bit creative and more inclusive in our recruitment methods. We started to see all this data, kind of affirming that most folks with binge eating disorder don't know they have it, don't get a diagnosis. And we started getting an accurate picture of what demographics or what populations have increased risk of binge eating disorder. But this information is ongoing. More is still needed. We need updated information on demographic prevalence, risk factors, pathology that includes the 55 to 95% of affected individuals who go undetected, unscreened, undiagnosed, and untreated. So again, this is published in my 2022 publication, Binge Eating Disorder is a Social Justice Issue. And I'm going to walk you through a little bit of the methods of how we got this data before I proceed to share more of what we found. So in my postdoc, I wanted to make a transition. My PhD is in biomedical science and neuroscience. That was preclinical. I was doing mostly stereotactic surgeries, focusing on neurobiological processes of addiction and withdrawal. And I wanted to make this transition in my postdoc to working in human clinical research, human samples, focusing on eating disorders. So, in order to get a pulse on the field, I developed a criteria to identify binge eating disorder experts globally. This included researchers, clinicians, healthcare administrators, policymakers. We actually had separate criteria for researchers and clinicians. The criteria was based on federal funding, PubMed publications, professional leadership, popular press, and Googleability. So I wanted to get a really good index of who are the people who are making the decisions that determine and inform what we think we know about binge eating disorder. But I also wanted to capture if you're Joe Schmo on the street and you have an eating disorder and you go on Google to find some help, who are you likely to access? So that's why we had this kind of Googleability criteria. So again, we had eligibility criteria for researchers and then separate criteria for clinicians. We also had a combined category for folks who had some research and some clinical criteria. That criteria identified 38 experts in total globally. Of those, 14, so just shy of half, consented to participate in 2-hour semi-structured, anonymously recorded Zoom interviews with me. Now, these are folks who develop the diagnostic criteria for binge eating disorder in the DSM, who have the most federal funding for the DSM. So these are really kind of, people who have a lot going on. So 2 hours of their time, I'm just immensely, immensely grateful. They consented to do semi-structured interviews with me on Zoom. The interviews were recorded and transcribed. This included 7 researchers or folks who met the research criteria, 6 clinicians or healthcare administrators, folks who met the clinical criteria, 2 who met the combined criteria, and 1 who met both the research and the clinical criteria separately. Again, so these participants did 2-hour semi-structured interviews with myself. We recorded the interviews, we transcribed them. I asked them questions pertaining to all aspects of binge eating disorder, from pathology to risk factors, environmental factors, biological factors, treatment factors, everything really that you can think of under the sun. Again, for the third time, here we go. We transcribed the interviews, and then we analyzed the transcripts qualitatively using retrospective thematic analysis, which is just a fancy name for a qualitative research technique. Myself and one other investigator shown here on the image, Heather Zwicky, who was my mentor at the time. She is the founder and director of the Health Got Research Institute, not the current director, but founder, has a PhD and is kind of one of the grandmothers of naturopathic medicine. We both went through the transcripts independently. We had analyzed them for themes. We identified themes, then we came back to each other, discussed the themes, and then kind of solidified them. Went back in, did some reflexive analysis, and then solidified the themes. And we've published the themes in these separate papers. So our first theme that was most robustly endorsed by experts focused on environmental factors associated with binge eating disorder, which were largely social justice issues. Our second theme was mental health aspects. Third theme was clinical aspects. Here's QR codes if you'd like to access any of those. You can also just go on PubMed, and there's only one Brenna Bray, so you can just put my name in PubMed and they'll come up. Fourth theme was complementary and integrative health use. So I'm going to focus on environmental factors. And there were 12 environmental factors that were most robustly endorsed by experts. Not only one of them had I imagined when we started this study. So the most commonly endorsed environmental factors that were endorsed by all experts were gaps in clinical research and care, invalidating environments and invalidating experiences, so invalidation, systemic issues and systemic oppression, marginalization, lack of resource access. Those 4 factors were endorsed by all experts in our study. Other environmental factors were economic precarity. The percentage here is a percent of experts who spontaneously, without prompting, endorsed that theme as a factor. So economic precarity, stigmatization and discrimination, trauma and adversity, food insecurity, interpersonal factors, social media and social messaging, nutrition scarcity, and predatory food industry practices and environments, which is the only one of those that I had predicted starting the study. So I'm going to walk through just a little bit of these themes. So the first theme, systemic issues and systems of oppression. There were 12 systems of oppression that were identified as relevant to binge eating disorder. These included systemic discrimination, endorsed by 82% of experts. Examples would be body weight, shape, size discrimination, structural racism, structural sexism, social media, sociocultural ideals, health insurance and healthcare systems, predatory food industry practices and environments, sexual, emotional, and physical abuse, geographic systems of oppression. So if you live in an area where SNAP benefits are not great, or you don't have access to a treatment center or something like that. Clinical factors in the field of eating disorders. So issues of justice, equity, diversity, inclusion, and access among healthcare providers. Anorexocentric understanding and engagement with binge eating disorder among healthcare providers, stigmatization among healthcare providers that we know drives healthcare avoidance and contributes to underscreening, misdiagnoses, underdiagnoses, and causing, very large percentage of folks to go undetected. That also stems from lack of training and education for healthcare providers in medical school, things like this. Federal funding for binge eating disorder research. I mentioned that binge eating disorder has 20 to 30% lifetime prevalence rates. That is the same as substance-related addictive disorders, depression, anxiety, yet we have about 1/100th of this federal funding, the amount of federal funding that is allotted to those other issues. I actually went through NIH Reporter and did the kind of calculations there. Economic exploitation, school systems, legal systems, police harassment. So a quote from one of the experts endorsing this theme: how we think about eating disorders is that anorexia was kind of the granddaddy, the thing we knew first. And then bulimia kind of grew out of that. And people used to refer to it as failed anorexia. And I would say in part that binge eating disorder was thought of initially as being like bulimia, but without the purging. So the same mechanisms. And I would say that traditionally, when I'm talking to my colleagues in the eating disorder field, the dominant mechanisms that have a tendency to be most thought of are things like restraint and shape and weight overvaluation. But that's starting to be a bigger push to have a more encompassing view of mechanisms like reward and inhibitory control, emotion, distraction, things like that. I think in part because the restraint stuff wasn't necessarily panning out with binge eating disorder quite as well. So why am I showing a dolphin? Besides the fact that it can lower cortisols a little bit and offer a little breakup in this presentation, I want to make the point that binge eating disorder, although it may look superficially similar to anorexia nervosa and bulimia nervosa because it involves a disordered relationship with food and eating, it is a very different and distinct diagnosis, with a very distinct psychopathology and biology and neurobiology. So here's a quote from one of our experts, and this quote was actually given in reference to something else, but I'm going to use it here. They said, I think in mental health, a lot of what we do, we see commonalities behaviorally, superficially, and then we make deductive applications. But dolphins and sharks look and behave quite similar, but one's a mammal and the other's not. If you look superficially, a lot of things can look the same, but I think we need to try and understand these more completely to see if such apparent commonality is supported. We need to review the data. So our second theme of marginalization and lack of access to resources had several sub-themes in it as well. So different types of marginalization that were described were low socioeconomic status and economic precarity or insecurity, food or nutrition scarcity, male sex or gender, or really sex gender minorities in general, racial and ethnic minorities, so member of the BIPOC community, Black, Indigenous, and people of color, age, religion. Now I want to give some data. I want you to remember that swag stereotype that we talked about. Maybe pull back in the, kind of demographic image of the person who you envisioned in the beginning. Now I'd like to tell you what the demographics of folks who have binge eating disorder look like. Members of the Black, Indigenous, and people of color, so the BIPOC community, have twofold higher risk and prevalence rates of binge eating disorder than their white peers. Yet they are 50% less likely to be screened, diagnosed, or receive care, and represented in less than 10% of research. So this is a systemic issue, and it is a huge one. So sex and gender minorities, members of the LGBTQ2 plus population, have almost 3 times greater risk and prevalence rates of developing binge eating disorder, 2.75. Gender minorities have 70% prevalence of eating disorders, 30% in binge eating disorder. They also go underscreened and are not represented. So what does this mean? I'm going to use a quote from one of the experts in my study. If you're a Black woman, if you're somebody who lives in a larger body, if you are an older male, people aren't going to think that your eating habits constitute an eating disorder because you aren't a young, thin, cisgendered white woman. I think it also makes sense to talk about the specific ways in which underrepresented groups might be struggling that are unique to them and their experiences, rather than just saying, oh, anyone can be affected. So knowing, for example, that if you are a sexual or gender minority, you are at much greater risk of any kind of eating disorder behaviors. Knowing that if you are a member of the BIPOC community, you are very unlikely to get detected with an eating disorder. And that means you could struggle for a long time. And what do we do then to reach these communities in a way that's meaningful? Food insecurity, so economic food insecurity and nutrition scarcity, was a third theme that was very commonly endorsed by experts, 93% of experts. I'm going to give a little bit of data here. So food insecurity increases risk for binge eating disorder 1.65-fold, almost twofold. Using government assistance before the age of 18 increases risk of binge eating disorder threefold. We have some data that has been done in food pantries, both in San Antonio, Texas, between 2015 and 2016. Their findings mirror studies that have been done in food pantries in Jordan and the Middle East, I believe. I can't remember off the top of my head, but they mirror studies that have been done internationally. They find that 52% of individuals who use food pantries report restricting their food or eating or fasting for at least 8 hours. Those who report this, that has significant correlation with increased weight and BMI and increased eating disorder pathology. And in fact, that 52% statistic, 52% also met diagnostic criteria for having an eating disorder. That is over half of food pantry users, just over half. The correlation coefficient with eating disorder pathology and increased BMI was 0.25 with a p-value of 0.0001. So a quote from an expert relaying something that was shared with her or him by one of their clients. Well, yeah, I have binge eating. I binge eat the first 2 weeks of the month because that's when we have food in the house. And then there's no food in the house the last 2 weeks of the month. So this offers a very different pathology than what we usually think of when we think of an eating disorder. And yet this is perhaps the most common pathology that occurs in binge eating disorder, or one of them, certainly. Now, these studies in San Antonio, Texas, that did this work in food pantries, they also had a qualitative component. So they asked participants why they were trying to restrict their food or eating, why they were trying to go 8 hours or more without eating. And the 3 most common reasons that they reported were insufficiency. So recognizing that their food allotment was insufficient, stretching food to make it last longer, and then the biology overrides and they might binge. Prioritizing other family members, so minimizing hunger for other family members. This would be a mother or a father who's trying to eat less so that their kids can have more to eat, again, knowing that what they have is insufficient. 3, prioritizing medical expenses, so using allotments on things like diapers and tampons rather than food. Again, this is a very different pathology than what we historically think of with eating disorders. This is not a person who needs a treatment to tell them to love and accept their body. I want to be very clear on that because that is what eating disorder focused cognitive behavioral therapy, that's pretty essential body self-acceptance. This might explain why some of our current standard of care have success rates that cap at below 50%, right? We might not be targeting what's really going on here. And prior to COVID-19, we kind of just didn't know. So here's another next theme, sorry, stigmatization and discrimination, also endorsed by 93% of experts. Now, there are a lot of different forms of discrimination that were identified by experts in this study. Stigmatization about body weight, shape, and size, stigmatization about having an eating disorder, stigmatization about having a mental health diagnosis. Here's a quote from one of the experts. I have a patient with binge eating disorder whose doctor told her, quote, "You're fat every day, so you should exercise every day." That's from a healthcare practitioner. But that's really what we're telling people as a culture or society. The practitioner just put it into words. And I will add that I also work as a behavioral health coach. I have had clients who have come to me in tears and have said, I was trying to talk to two clients who've said, I was trying to talk to my doctor about my CPAP machine. And my doctor told me, you need to lose weight, and we'll talk about your CPAP after you lose weight. One of those clients advocated for themselves and said, no, we need to address my CPAP. They got testing. A week to 2 weeks later, the doctor called them back in and said, I'm so sorry. This has been contributing to your weight issues. I'm really sorry. So we really need to start rewriting the narrative of what food, eating, and weight disorders are. We really need a better understanding of them. The sources of stigmatization, as identified by experts, were internalized, so at the level of the patient, systemic, sociocultural, contributed by social media, etc., and specifically in healthcare providers and healthcare systems. I cannot stress how important this is. This is a major source of stigma, and it contributes to healthcare avoidance, which then leaves many individuals with binge eating disorder undetected, undiagnosed, and struggling on their own with their issues. The impacts of stigmatization also cannot be understressed. They induce shame. They induce very real trauma, both little t and big T trauma, as well as PTSD and adversity. They are a primary source of adversity. They can show up as forms of adverse childhood and lifetime experiences, contribute to PTSD, poor self-esteem, interpersonal relating, isolation and avoidance that begets binge eating and worsens mental health. And then, as I mentioned, healthcare avoidance that contributes to undetection, underdiagnosis, and underscreening. Another quote from an expert, if the eating disorder has been associated with weight gain, then we know for a fact that the individual has been intruded upon by families, doctors, institutions, and there's trauma associated with that. There's trauma associated with being told day in and day out that what you are is not acceptable or lovable or okay. Many people who are living in larger bodies have been teased or bullied around weight, so there's a lot of trauma associated with binge eating disorder. For those of you who are providers and you may have individuals who have high weight, fully understand that can increase risk of other health issues. You need to address that. Please proceed with sensitivity and understand that you are going to be treading on a landmine for someone. So another quote, and I think I read this one already. If you're a Black woman, if you are somebody who lives in a larger body, if you are an older male, people aren't going to think that your eating habits constitute an eating disorder because you aren't a young, thin, cisgendered white woman. Now, I've already read this quote. I'm showing this because, as I mentioned, I direct the Nourished Research Foundation. We use research to help improve awareness, understanding, prevention, treatment, and clinical and lived experiences for folks, not just with eating disorders, but also with a variety of health disparities. We aim to kind of tackle this issue on 4 different levels. So we provide resources that are accessible for folks who have binge eating disorder or other mental health disparities and might not have access to healthcare. We provide trainings to healthcare providers and organizations. We use research to help improve our understanding of these types of eating disorders, inclusive research. And we also use social media campaigns and public speaking to help change the environments that eating disorders occur in. So this quote and this infographic that you're seeing was one that we posted on our social media posts in one of our campaigns. As you can see, it got very high engagement. So we had 120 people engage, give an emoji, give a response. There were 68 comments and 4 shares. Now we actually have one of our research interns, created this infographic. Barbara Kalu, she's a clinical mental health master's student at Johns Hopkins University. She created this, we launched with, we had all this engagement. I thought, oh, that's great. And then I looked at the comments and they were atrocious. I met with Barbara. I shared this. I was so heartbroken. I was thinking, man, we're just enabling here. And Barbara said, would you mind if I take some screenshots of those comments? I said, no, go right ahead. And at our next meeting, she came back to me. We're kind of talking at the end of the meeting. She said, could I show you the reel that I made for our next social media post? And I said, yeah. And this is what she showed me. And now what you're about to see are all of the very real comments made by folks in response to this post. Anytime you're given the message, overt or covert, that something is wrong with you, like you're bad, you're too much, you're big, you're repulsive, you're gluttonous, whatever, that's really the message that people internalize through a lot of experiences with healthcare providers and other organizations. Nourish Research Foundation is a nonprofit dedicated to nourishing knowledge and empowering hope for eating disorders for everyone. So I like to show this because I think it is a really good example of the extent, the pervasiveness of the stigmatization, the discrimination, the bullying, the abuse, the adversity that many folks who live in larger bodies and many folks who experience binge eating disorder and other eating disorders experience on a daily basis. So again, this is that quote. The last part of, so anytime you're given the message, overt or covert, that something is wrong with you, you're bad, you're too much, you're big, you're repulsive, you're gluttonous, that's really the message people internalize through a lot of experiences with healthcare practices, practitioners, families, schools, etc. So I'm going to kind of wrap it up here a little bit. But a next theme that was very highly endorsed was trauma and adversity, very highly related to stigmatization, which we just talked about. Relevant forms of trauma and adversity that were identified by experts are listed here on the right. These include conventional adverse lifetime experiences and adverse childhood experiences endorsed by 29 and 14% of experts. These would be kind of your traditional abuse, neglect, household dysfunction. We do have data showing that a single adverse childhood experience, especially involving restricted food access, so food insecurity, which actually is a very real form of adverse childhood experiences, increases the odds of developing binge eating disorder threefold or 2.95. And usually, when folks have one adverse childhood experience, they have more than one. We have a lot of data showing that trauma and adversity have very real impacts on the brain. And I'm not going to go through this data so much just for the sake of time. I'm happy to come back to it to the discussion if you want. Over here on the left, though, you're looking at a very healthy, active brain. Over here on the right, you're looking at a PT scan of a chronically institutionalized Romanian orphan. And there are actually several, so there are statistically significant differences here. And you can see that it is less active, it has more atrophy, things like this. So we know that trauma has very real impacts on the brain. We also have other forms of trauma and adversity that were endorsed by experts. These included body weight, shape, size, stigmatization, invalidation, oppression, marginalization, interpersonal trauma, mandated movement, food insecurity, especially as a child, chronic dieting, and as I mentioned in the beginning, untreated other diagnoses. So untreated ADD, ADHD, untreated autistic spectrum disorder, PTSD, etc. The mandated movement, I'll talk about a little bit more in a bit. So if you're questioning what that is, I'll come back to that. I do want to acknowledge, as I'm showing here in the left, these types of adverse experiences are gaining recognition in the literature base. We tend to call them expanded ACEs or expanded ALEs. And we also have data showing that these expanded forms of adversity also have very real neurobiological impacts. So this is Nicholson 2022 showing the neural correlates of sexual minority stress, which is experienced very highly by individuals with eating disorders, showing that it impacts the default mode network. It impacts the salience network. So it increases our reward threshold, makes folks hypersensitive to reward and reduces their capacity for reward regulation that can facilitate and prompt binge eating. It also impacts the central executive network that can contribute to the high comorbidity with things like ADD, ADHD, etc. I want to point this out because this is not just an issue of being able to cognitively not binge eat. There's a very real neurobiological underpinning here to about 80% of the data that we have shows about 80% of folks who have binge eating disorder also meet diagnostic criteria for substance use disorder or now substance related addictive disorders using the DSM criteria if substance and paraphernalia are substituted for food and eating. And that's using Ashley Gerhardt's Yale Food Addiction Scale. Happy to talk more about that later. Ashley Gerhardt was one of my external mentors in my postdoc. So we know that people who are traumatized can have upsetting of their arousal responses that is biological, and that managing and downregulating the hyperarousal response is an important part of therapy often. We know there are biological brain changes that occur as a consequence of repeated adverse or traumatic life experiences. We know that PTSD is a disorder that is a common outcome, but that people can also develop other disorders which are not PTSD, but that occur as a consequence of repeated adverse lifetime experiences. As part of that dysregulation of emotions and those experiences, binge eating can become a way of modulating these emotions. It's a real phenomenon and a real effect. And lots of research shows that traumatic early life experiences of all kinds can increase someone's risk for an eating disorder. Again, that's from an expert in the study. So I'm just going to kind of touch on mandated movement, and then I'll kind of move it into the end, wrap it up here. So I mentioned mandated movement. This would include, there's a challenge in the field we published in our 2023 publication on clinical aspects of binge eating disorder. There's a challenge in the field of how you address the issue of weight in folks who have binge eating disorder without adding further stigmatization or trauma. So one expert said the trauma of physical activity, the idea that they don't want to work out, but it's really that their middle school teacher was screaming at them when they were trying to do their mile or whatever in gym class, or they got made fun of. And we actually do have some data supporting this. So this is from what I'm showing here is from a publication published in 2018. My best memory is when I was done with it. Physical education memories are associated with adult sedentary behavior. And this is showing the number of folks, I believe, with eating disorders, respondents who report having some kind of trauma or adversity related to their physical education experience. So again, as providers, if we have folks who live in larger bodies, and this extends beyond eating disorders, we need to be very sensitive with how we address that. We need to understand that for these individuals, we are working with trauma. One thing I want to point out here on that note of trauma is that there was a lot of thematic interaction, right? So some of the primary themes that were endorsed: invalidation, marginalization, stigmatization, discrimination, trauma, adversity, interpersonal relations. These are all really forms of trauma and adversity. They interact, and folks who have one are more likely to have more than one. This is Barbara Kalu here on the right, who I mentioned before. She is a clinical mental health counseling master's student at Johns Hopkins University. She's a staff member at Nourish. She does all of these beautiful infographics that you've been seeing in this presentation. When I try to do an infographic, they do not look this nice. I also want to bring this up because this research that I've presented is primarily qualitative. That's not my background or training. I was trained in neuroscience and biomedical science. I was not really thrilled to be doing qualitative research in my postdoc, though I do find that it is extremely valuable and rich. But it can be very hard to present because we tend to not have graphs, figures, things like that. Showing quotes, it can be an eyesore. So we have another staff member at Nourished, Rishi Lamashane, who is starting his master's in public health at Brown University this fall. Rishi is a biostatistician. He came to me at Nourished. He was really interested in biostats, and I said, that's great. I teach stats, and that is about, I know the bare minimum that I need to teach. I'm not a statistician. I don't know how to teach you what you want to do, but I know how to mentor you to guide you. So Rishi basically developed a social network mapping protocol that he applied to the environmental factors that experts endorsed in the field. And this is just a little image here. We're getting ready to publish this data, but it's just a really nice, new, unique way to be able to visualize some of these findings. And with that, I'll read this one last quote and then we'll close. If you work with eating disorders, it's a political statement, especially as we're better understanding the impacts of racial injustice. Targeting inequity is going to have a cascading effect across mental illnesses, and especially the way we understand the impact of discrimination. There's no question we need to be thinking about broad-based social factors related to poverty, related to stigma and weight stigma, obviously, and binge eating, but frankly, all types of stigma, all types of discrimination, because binge eating crosses demographics, gender, and my guess is binge eating disorder is horrifically underdiagnosed among people who aren't currently on our radar. So what can we do? Number one, la tabula rasa. Blank slate. Forget what you think you know about eating disorders. We need systemic screening among providers, especially in marginalized populations, your CMS patients, your members of BIPOC community, LGBTQ2+, etc. We need a better understanding of weight bias, stigma, discrimination. I'll add right here, these notes are things that were identified and most highly endorsed from experts. We need to be including patient experience and impact, implicit understanding of weight bias, stigma, discrimination in the field. Number three, taking and raising the patient narrative. Again, forget what you think you know about eating disorder, listening to our patients, asking questions. I think we need to be taking account of people's narratives and life experiences, and that should be informing our therapy and our therapeutic approaches. We also need accessible and inclusive treatment options that are free or low cost, can be delivered virtually or community-based, are accessible to folks who lack access to healthcare, are socioculturally sensitive, inclusive, and responsive. That can overcome the treatment barriers of treatment non-responsiveness, lack of access to healthcare, lack of formal diagnosis, lack of understanding of binge eating disorder. I put out a publication on Overeaters Anonymous, which is a 12-step fellowship that has high potential impact for binge eating disorder. We're getting ready to kick off a study to test the feasibility and efficacy of this intervention. There are many others too. What can we do as clinicians? Social justice therapy is very worth exploring. Trauma-informed therapy for sure. Again, recognizing the pervasive nature and impact of trauma, asking to our patients not what's wrong with you, but what happened to you. Focusing on safety, understanding trauma, empowerment, healing, and avoiding re-traumatization. Now, I teach at Naropa. I teach in a Buddhist-informed contemplative counseling clinical mental health cohort. Buddhist-informed contemplative counseling has a lot of really rich interventions that have high impact here. So the concept of basic sanity or brilliant sanity, acknowledging the basic sanity in all of us, the capacity for healing, self-awareness, growth, honoring the brilliantly sane clarity and wisdom in each of us. A simple act that we can do is person-first language. So an individual with binge eating disorder, right? Non-dual therapy or non-interference therapy. So the idea that there's nothing to be done, that these folks might be doing the absolute best that anyone could in their situation. Offering compassion, empathy, acknowledging, again, the basic sanity, innate capacity for healing, self-awareness, and growth. Non-dual therapy also has a very large empirical base. And as I mentioned at Nourish Research Foundation, we're really kind of doing what we can to address this issue. I think I went a little bit over. Thank you so much for the